good techniques there to look at posterior column and jumping the symphysis, both which can be a little challenging and I think a really useful tool and application for the CurvaFix device. I'm going to go over my case series for my first nearly 40 patients. Sort of similar to Matt's study with a slightly less patient volume, but I think one of the things that people often ask about new implants and new techniques is, where's the data? Show me the data. Well, we're doing that. We're getting it. We're trying to get it out to everybody so they can see the different techniques, not only, but actually the results of some early case series. So we wanted to look at the use of CurvaFix, or the percutaneously placed intraosseous curved pelvic device, and try to help identify where it's most useful, what its findings are in this complex anatomy. The pelvis is a ring. It's pretty common. Everyone calls it the pelvic ring. We're still using straight screws in a lot of these places. So looking at some of the applications for more curve fixation to accommodate the native anatomy in these patients and trying to overcome some of these obstacles. So we did a retrospective review of my first 39 patients. This was all comers pelvic and acetabular fracture patients. No age limitations, so we looked at both geriatric and high energy patients. Standard patient demographics and history were also recorded. And our main outcomes were recording the time to weight bearing for all of these injuries, and also looking at time to union and recording any complications in the series. So in my results with the first 39, we had a mean age of a little bit more of a geriatric population, almost 69 years old. 2/3 were female, which I think if you look at where I practice in Cleveland, Ohio, we have a very high population of geriatric Caucasian females with osteoporosis that don't often see the sun. So that population was no surprise to me. We looked at pelvic ring injuries that had a chronic injury or two in this group, also acetabular fractures, and patients with multiple combined injuries. The mean time to weight bearing for all comers was about 3 weeks, 22 days, that they were able to comfortably weight bear without pain. They were all made weight bearing as tolerated from the get-go. So this would be someone who was comfortable ambulating, standing in double leg stance, and then performing single leg stance on their injured side with this implant. And the mean time to radiographic weight bearing using X-ray, which is challenging, and I'll mention at the end as limitation, was about 18 weeks. My typical patient follow-up is usually 6 weeks, 3 months, and 6 months. So most patients at 3 months had radiographic union. There was maybe 1 or 2 that sort of upped that average because I didn't see them back for then 3 more months. One of the more notable results, at least in my series, was that some of the more significant comorbidities such as osteoporosis, diabetes, and tobacco use did not affect the patient's ability to weight bear or their radiographic union. So to me, that is very helpful, especially in the geriatric pelvic fragility population. As Brett started off talking about, this is one of our focuses with this implant to get these patients up and going. So there was no increased complications or delay in weight bearing or union in that population. I did have to take one patient back to remove an S2 screw that had an S1 CurvaFix, which was my only complication to return to the OR that was unrelated to the CurvaFix. So just some of the data from the study, as I mentioned, the age was closer to 70 years old, predominantly female, predominantly Caucasian with a non-obese BMI. The average A1C in this population was close to 7, which was pretty high, and about 1/3 of them were osteoporotic. The tobacco use there is listed, either former or current, and a lot of these patients, like I had to laugh when I was going through this data because I can recall even about 5 or 6 patients to say they quit smoking, and it was like they quit smoking like a week ago. So that's what was recorded. But a lot of these elderly patients that have been lifelong smokers have sort of that reflection in their bone mineral density. And then the fracture patterns are also listed there. So you look at the event, time to surgery. We try to get everyone to surgery within 24 hours when it comes to patients that have an immediate indication. But again, circling back to Brett's talk at the very beginning, we're trying to give some of these patients, especially in the fragility population, at least 48 hours to try to get up and try to move. So I'm not surprised by that, about 48 hours to get to the operating room. We have a very similar protocol as the Missouri group does. Oh, I think yours is 72 hours. Yeah. We try to do 48 hours to give patients effectively 2 chances with physical therapy to stand and walk to the bathroom. If they can't do that, the correlation is that they can't take care of themselves at home, they can't perform personal hygiene, they can't then get from a couch to the refrigerator to feed themselves, and they can't go to the bathroom. So as long as they can demonstrate that, then they don't go to the operating room. In this group, so it's about 48 hours time, discharge about 1 week, 7 days, and again, 3 weeks with weight bearing, and the rest of the union data is up there. This was from a abstract we presented back in January, so the follow-up time is now significantly increased, closer to 8 months, at least average in this group. Duplicated there, my bad. So again, if you look at some of the data, we have no significant differences in terms of weight bearing or radiographic union when you look at all of the demographic data that we collected and the risk factors, again, tobacco use, diabetes, and their fracture pattern, as well as concurrent injury. So we concluded that this curved flexible implant is safe. We didn't have any complications related to the implant itself, no implants backing out, no implant breakage, no failure of reduction or delay in time of union. They were all able to achieve early weight-bearing status. And despite some of these risk factors that we had listed there, the patients did not experience any increased complications due to that. So I thank you for that.